Chapter 19, Part 2, Cardiac Physiology, Screencast 6. This is the last screencast for Chapter 19, and it is going to focus on variables that impact stroke volume. Remember, stroke volume is one of the parameters necessary to calculate cardiac output, and we're also talking about the amount of blood that is ejected from the ventricles every time the ventricles beat. There are a number of things that are going to have an impact on stroke volume: venous return, inotropic agents, and afterload. Venous return is the primary factor. Now, let's keep in mind, quite often we think about blood leaving the heart but not coming back. Remember, the cardiovascular system is the only homeostatic system that has no opening to the external environment. So it has to come back to the heart, and it's going to be driven by pressure. And venous return is going to determine ventricular filling. So remember, one of the things that I've talked about, making sure that the ventricles have adequate time to fill completely. It really is about venous return. If we increase venous return, we're going to see a corresponding increase in stroke volume. So there's a direct relationship here. Now, keep in mind, venous return is determining the amount of blood in the ventricle prior to contraction. So really, it's end diastolic volume. So this volume is really determined by preload, and we like preload. The pressure from the stretching heart, because good ventricular filling, is going to be some shortening. So that's really good here when we talk about that. There's a little bit of a stretch that's due to the enhanced ventricular filling, and our ventricles are nice and full. Now here we can basically look at the relationship between these three parameters. We have venous return, inotropic agents, and then we're going to have afterload. Okay? So one of the things that we have to keep in mind here, venous return, how much blood is being returned to the heart, that's going to have an impact on stroke volume. If we have a little bit of stretch, we'll see why this is important. That is going to have an impact on stroke volume. Afterload, we will find, is resistance. We're going to use high blood pressure as an example of afterload. And then when we look at inotropic agents, those are going to be external or extrinsic factors that will have an impact on contractility. Keep in mind, we're talking about inotropic, not chronotropic. Chronotropic is going to impact heart rate. Inotropic is impacting stroke volume. So here we're basically looking at the impact of end diastolic volume versus end systolic volume. And once again, that's how we calculate stroke volume. And once again, it's going to be impacted by venous return, which we want to maximize, inotropic agents, which are going to impact calcium. And then we have afterload, which we're going to look at as something that is negative and will negatively impact stroke volume. Now, Frank Starling law of the heart. This is a really important concept. This is an intrinsic factor and is related to the fact that cardiac muscle is striated. So what this law basically says, as end diastolic volume increases, there's a little bit more stretch on the heart wall, and that is going to result in more optimal overlap of the thick and thin filaments. I hope this sounds familiar because this was first introduced to you in Bio 144 when you were covering muscle physiology and talked about making sure that you are maximizing cross-bridge formation, and that had a result in increasing contractile force. Same thing here, because remember, I've put that emphasis that cardiac muscle is also striated, and it's going to act very, very similar to skeletal muscle because they share the same architecture, and the functional unit is the sarcomere. So now, because of this, the heart contracts more forcefully when filled with more blood, so stroke volume increases. You're taking advantage of this optimal cross-bridge formation. Venous return may be increased by increased venous pressure or an increased time to fill. That's what we see in trained athletes. So their stroke volume is going to be much more forceful when we actually see that. Now here, this diagram is basically showing you the significance that just a little bit of stretch makes on the amount of force that's being produced. Here, if we look at 0, okay, we actually see a little bit overlap of the thin filaments, so we're not going to see a lot of force being produced here. But then as we start to see a little bit more stretch actually added, we will see a corresponding increase in the force of contraction or tension that's being produced by the ventricle. So this really is important here, and it's really showing us how important it is to make sure that we have nice full ventricles, and that is going to maximize what we see with respect to stroke volume. Now, when we look at venous return, there are some things that are going to have a negative impact on venous return. Let's kind of think of someone that has a low blood volume. This could be due to a hemorrhage. This could be due to dehydration. It also could be due to a high heart rate in which we're not getting as good ventricular filling. This basically results in a much smaller end diastolic volume, so preload is decreased. As a result of that, we're going to have a smaller stroke volume. Now, we talked about balance, and it is the Frank-Starling law of the heart that basically is ensuring that this balance between the ventricles is taking place. As one side is receiving a little bit more blood volume, it's going to contract more forcefully. That leads to greater fill and more forceful contraction on the other side. So this is making sure that we have that ventricular balance that we talked about previously. So I hope you understand how important this Frank-Starling law of the heart is when it comes to addressing stroke volume. It also explains what we see with respect to why endurance athletes have a stronger heart rate, or lower heart rate, excuse me. Now, here, let's kind of walk through the impact of venous return via this diagram. And so once again, we have increased venous return, and this can happen one of two ways. It's going to be greater venous pressure or a slower heart rate, which allows for greater ventricular filling. We see a stretch of the heart preload, and that results in more overlap of the thick and thin filaments within the sarcomere of the myocardium. Once again, we are maximizing overlap. This means we have additional cross bridges that are being formed, and this results in a much greater contractile force, resulting in an increase in stroke volume. Now, here we're going to talk about inotropic agents, and this is going to be these extrinsic factors that will have an impact on stroke volume. So we're really looking at things that have an impact on contractility. The biggest factor here is going to be calcium availability. This also kind of goes back to what you learned about skeletal muscle. Calcium will bind to troponin, and troponin will cause tropomyosin to free more binding sites for myosin and actin, so you're going to form a greater number of cross bridges. So if we have an increase in calcium, we will have more cross bridges. A decrease in calcium will result in fewer cross bridges. Now, a positive inotropic agent is going to be anything that increases the availability of calcium. We've already talked about the role of epinephrine and norepinephrine and their impact on beta-1 adrenergic receptors. They overall function by increasing calcium availability. So not only does this increase heart rate, it also will increase contractility and stroke volume. We kind of look at what thyroid hormone does. Thyroid hormone will increase the number of beta-1 receptors, hence a greater impact of epinephrine and norepinephrine due to the increased number of beta-1 receptors. There are also a number of drugs out there that might have an impact that are considered to be positive inotropic agent. The best one that I can give you is digitalis. This is a drug that's very commonly used to treat individuals that have heart failure, and it basically increases cardiac output by increasing contractility, by increasing available calcium. A negative inotropic agent is going to be anything that decreases the availability of calcium, so less calcium, fewer cross bridges, decrease in stroke volume. Something that could act as a negative inotropic agent could be an electrolyte imbalance, but also it's probably more common are certain drugs such as calcium channel blockers, and those are a very common drug that are used to decrease high blood pressure or to treat high blood pressure. So now let's kind of take a look at these inotropic agents. So once again, substances that act on the myocardium to alter contractility. If we look at a positive inotropic agent, basically stimulation of the sympathetic nervous system, we're going to have a greater amount of calcium. This creates more cross bridges being able to form. And then once again, whenever there's more cross bridges, a greater force of contraction, and this will result in an increase in stroke volume. The opposite happens when we see a decrease in available calcium. So we'll have a decrease in stroke volume that is attributable to lower levels of calcium, resulting in fewer cross bridges being formed. Now, I've talked about afterload, and afterload is bad. Let's think of high blood pressure. So now we have resistance in the arteries, and now the heart actually has to work harder just to open the semilunar valves. So really, we're not going to have as much force left to actually eject blood from the ventricles. The primary cause of this is going to be atherosclerosis, and this is that plaque that's forming in the lining of the vessels, and this is a perfect example of afterload. So what we see is a smaller lumen of the artery. This increases the resistance, so the heart has to work harder just to open the valve, so there's not as much force left to actually push volume, blood, out of the ventricles. Now we have a decrease in stroke volume. So here, let's kind of take a look at the impact of afterload. So once again, it's resistance in arteries, and primarily this is due to atherosclerosis. So we increase resistance, something that happens as we age. It's a chronic process. The arteries will become narrow in diameter. This will be really important in the next chapter when we talk about contributors to resistance in our vessels. And because there's a greater resistance, the heart has to pump harder to overcome that resistance. And because so much more effort is focused on opening the valve, there's not as much force left to actually squeeze blood out of the ventricles, hence a decrease in stroke volume. Now, once again, let's try to start putting this together. And when we look at cardiac output, it varies directly with heart rate and stroke volume. Heart rate is going to be impacted by those agents we refer to as chronotropic. These agents basically act by having impact on the SA node to change the firing rate, influence the AV node to alter amount of delay. So that's basically how we're going to see these agents work. Stroke volume is all about what's happening to the myocardium. Venous return will have an impact on stretch of the heart, and inotropic agents will influence cross-bridge formation. Increased afterload, which we see on the arterial side of thing, decreases stroke volume. This is especially something that we see in older individuals because atherosclerosis is a chronic disease. Now, if we look at this particular diagram, it's really tying together all of the things that have an impact on cardiac output. So here we look at chronotropic agents. So once again, they're primarily impacting the SA node. Positive agents are going to result in an increase in heart rate, whereas negative will have a decrease. Once again, we'll see a direct impact on cardiac output. Cardiac output will increase with an increase in heart rate or decrease with a decrease in heart rate. Now, venous return, so this is all about that ventricular filling, and we're really looking at the Starling law of the heart. So that is directly correlated with stroke volume. So at the increased venous return, I'm going to increase stroke volume. If I increase stroke volume, we're going to see an increase in cardiac output. Now, we have these inotropic agents. We have positive agents. They basically will increase contractility by creating more cross bridges, whereas a negative agent will decrease calcium availability, decrease stroke volume, hence a decrease in cardiac output. Afterload is inversely correlated with stroke volume. If we increase resistance or increase afterload, this is going to result in a decrease in stroke volume, hence a decrease in cardiac output. Now, the last thing that we want to kind of take a look at are what we consider to be bradycardia and tachycardia. You may hear the terms brady and tachy with respect to heart rate. A bradycardia is typically a low heart rate that's persistently below 60 beats per minute. And when we look at an athlete, this is normal. It is a factor of their endurance training. The heart becomes stronger, stroke volume is higher at rest, so it doesn't have to beat as many times per minute to meet resting demands. Some situations that may result in an abnormally low heart rate could be hypothyroidism, some type of an electrolyte imbalance, and also heart failure. Tachycardia, this is a heart rate that is persistently high, typically over 100 beats per minute. And it could be something that's due to heart disease, it could be due to fever, and it could be due to anxiety, just to name a couple of factors that could contribute to this.